Just a few logistics as we get started today. I know a lot of you asked about hot water. So hot water is brewing, and we are refreshing the hot water. So there will be more hot water for the afternoon, but let's hear it for the staff who put together that amazing lunch. Thank you all, and with that, we'll turn it over to Dean Barton.
Thank you, David. Welcome back, everyone. That was an incredible morning. I hear so much buzz, and people are talking about how are we going to fit these programs in, where are they going to go, and how are we going to do this, and it's very rewarding. Just a couple of things. I never did introduce David Flinchbaugh. Not only is he a great carnival barker, but he is also our Director of Development and Alumni Relations. And he mentioned that some people have asked, how is this event funded today? And in his role, it's very appropriate. I should answer the question and should perhaps made it clearer that we received a gift from the Allison and Arnie Richmond Fund. Some of you know a family fund. Some of you know Arnie and Allison. Allison is an alum of our school and was on our board for many years. And it was called the Dean's Innovation Fund. So this was some years ago now, and it allows me to take the interest off each year and do something that's useful. We've had some prior series. One of them was on technology and serving SMI, serious mentally ill clients in their homes and in community settings. One series was on motivational interviewing, where we developed better motivational interviewing training for the entire school. And this is the third series. These are short series, but on parenting intervention. So thanks to Allison and Arnie. Thanks to Dave. If anybody else wants to contribute, he's got a good inside pocket. And there's also a link on the back of the program. So with that, I'll turn this back over to Lisa. Thank you.
Thank you so much. Thank you, Dave, indeed. Now, I'm so pleased to introduce Dr. Nancy Stockman, who is an associate professor of psychiatry at the Yale School of Medicine, where she focuses on developing and evaluating attachment-based parenting interventions for mothers with substance use and psychiatric disorders. She's developed this program that she's about to describe, Mothering from the Inside Out, that I think you'll find really fascinating and important. So, as you can see, the title of her talk is Mothering from the Inside Out, Enhancing Maternal Reflective Functioning and Caregiving Quality of Mothers in Treatment for Substance Abuse. Welcome, Dr. Stockman. Yeah, sure.
You have a pocket?
I don't.
Okay, thank you. It's really an honor to be here presenting with my colleagues here, whose work I've known and respected for many years. Where can I slide? Oh, that way. Okay, so it's actually so beautifully ordered because I'm really going to be picking up on what Mary was talking about at the end of her talk, her comments. And I want to talk first about addiction and the brain, and then parenting and the brain, and then how that kind of leads to the rationale for mothering from the inside out. If you think of a favorite food or substance or activity that you have done in the past, and it might help you understand the process of addiction and the brain, because addiction powerfully affects the reward centers in the brain. And I'm thinking of a friend who I went hiking with last weekend who really remembered a gelato that she had in Italy, a certain flavor, and she remembered where she had it, when she had it, what it was like, and was looking forward to having it again. And so what happens when we engage in activities that are necessary for survival like eating or procreation or social interactions, is that there's a release of dopamine, the pleasure substance in the brain. And that leads us to feel, that felt great. Let me remember where and when and how this happened. Let me do it again. These are all associated with different parts of the brain. Let me focus on this. And so dopamine and other neurotransmitters are released. Oxytocin is also probably involved. And so you get this great feeling of satisfaction. So it's a positive reward that gets you to do it again and again. Now I want to switch to talk about the neural circuitry of parenting, which also involves the reward system. And this is work done by Lane Strathern at Baylor University, where he had mothers of infants from, I think, 5 to 10 months old, who came in and he took pictures of them somehow when they were happy, when they were sad, and when they were neutral. And then the mother went into the magnet, the MRI, and he looked at what got activated in the brain. And lo and behold, and not surprising, he found that when parents, he also had pictures of unfamiliar babies showing the same 3 expressions. And so what he found was mothers' reward centers in the brain became more activated when they saw pictures of their own babies in happy, sad, and neutral. And so there was more of a neurological reward seeing their own babies than unfamiliar babies. There was also more oxytocin in the blood. And so thinking about the attachment cycle, how this can be interpreted is that when an infant cues the parent with an emotion and the parent responds in a sensitively and timely manner, and the infant responds with soothing or joy, there's a chemical reaction in the brain of the mother that reinforces her responding to the infant and also helps her manage the parenting stress again and again and again. Now, if we switch to looking at mothers with addiction, the research that's been done observing particularly mothers who are, have been in methadone maintenance back to the 1980s has shown that, that in their interactions, mothers are showing less sensitivity, more intrusiveness, more harsh parenting, more withdrawal, more neglect, and also, interestingly, a juxtaposition between withdrawal and intrusiveness. So the question is, why is that? Why are we seeing that behavior? And so now, with the neuroscience of addiction, we know that when a mother starts, or an adult starts using drugs and gets drugs on board, regardless of the drug, there is an increase in the dopamine release and the other neurotransmitter releases in the brain. And so that's what, how many of you work with addicted parents? Okay, so you've heard, I'm sure, the parents describe the experience of using opiates or using cocaine, the euphoria that comes over them, and how it's unlike a euphoria that they've ever experienced. And so what's happening is that first their addiction is getting primed by this positive reward. There's 20 times as much dopamine released, sometimes instantly if it's a very direct, like intravenous use of the drug. It's also longer lasting. And so the brain adapts to this. And the way the brain adapts to this is that the straws in the brain that drink up the dopamine start decreasing. The brain takes up less and less of the dopamine. And so now the addiction it turns the corner and becomes negatively reinforced because the mother has to use more and more and more of the substance in order to get the same effect. So she's developing a tolerance. The other thing that's happening is that activities like parenting, eating, procreating are no longer experienced as pleasurable because they're not producing the same amount of dopamine in the brain. And so, so she's caught. And so it leaves mothers feeling flat, sometimes depressed, stressed about parenting, not able to enjoy parenting. There's now neurological research that's coming out that's replicating Strickland's earlier research, showing that mothers with histories of addiction compared to mothers who don't have histories of addiction, when they see pictures of their babies in the MRI, when they're in the MRI, their babies showing happy faces and sad faces are showing a muted neural response in comparison. And so addiction, as Mary said, is hijacking the brain and taking away the pleasure of parenting. There are also lower levels of oxytocin. And so if you think of the change in the parenting cycle now, and we think of this as a way of interpreting those earlier behavioral findings, now when the infant cues the mother, there's no neural reward. There's no anticipation of a neural reward, and there's heightened stress. And so the mother moves into more of a fight or flight mode, where in order to survive, she either needs to control this toxic stimulus of the infant crying or withdraw and get away from it. And we even think that it might be related to her relapses. And Helena Rutherford at Yale is actually doing research on this fight or flight mode right now. So what are the implications then for intervention? First of all, treatment and addiction, treating addiction and parenting at the same time may have a positive synergistic effect. If a mother can experience more pleasure as a parent, she may show a reduction in her cravings for use. And if a mother stops using, she may be able to be more present. But the two are intertwined, and so we think it's important to treat them together. We also think it's important to target the mother's emotional regulation that's particularly related to her parenting stress, as well as other relational areas in her life. Because if she can regulate her emotions while she's in recovery and hang in there in the parenting relationship, it's likely to get better. We also think it's important to allow the mother to lead you. It's sort of like we're talking about following the child's lead. Here we're talking about following the mother's lead in terms of what is she distressed about, so that you have a chance to help her think about and regulate the distress. And so that involves assisting the mother to notice, understand, and regulate her own affect. And also to be able to recognize and understand her child's emotions, and particularly her child's difficult emotions that are activating her. And so this is why we ended up turning to a mentalization-based intervention in order to promote emotional regulation in attachment relationships. And so what is this big word, mentalizing? Why is it important? How does it develop? This is a really classic cartoon. It's like you haven't heard a single thing that I've thought. That's a mentalizing problem. So mentalizing is something that we do in everyday life. We do it automatically, we do it unconsciously, we do it implicitly. It's really how we understand interpersonal relationships. It's thinking about, it's sort of thinking from the inside out. It's thinking about how others affect our own thoughts and feelings and wishes, and also thinking about how we impact the emotions and thoughts of others. It involves thinking about behavior in terms of underlying emotions. It's necessary for talking about interpersonal conflicts to understand the other person's experiences, your experiences. It's obviously important in parenting to understand children's mental states and parents. It's nothing new. It's something that we do all the time, and it's something that you do as clinicians all the time. and these are just examples. An employee may be wondering what's going through their boss's mind when the boss is losing their temper, or a mother's wondering what's going through the infant's mind when the infant is crying. A teenager may be thinking about how their own impulses are leading to cravings. And therapists think about what's going through the mind of my patient when she's upset. Again, it's nothing new. It's important, though, and we're highlighting it in therapy because we think that it's important to draw more attention to it, draw more attention to mentalizing in relationships. The opposite would be mind blindness, which is characterized by autism. It's really the antithesis of mentalizing. It allows us to distinguish where our own thought process ends and where another's thought process begins. And so if you think of a mother talking about a child saying, oh, he's afraid right now, it's a way of sort of distinguishing her own emotions from the child's emotions. It's also a way of distinguishing intrapersonal mental processes from interpersonal and intrapsychic events from external reality. So for example, you might think, oh, my boss looks mad, or my boss is frowning, I wonder what I did. But then you start thinking about all the other possibilities of why the boss might be frowning that has nothing to do with you. And so it's being able to make those distinctions. And then finally, it involves making sense of and evaluating and ultimately regulating visceral affect. So oftentimes, children and infants especially experience affect in their bodies. And then the parent might say, oh, you look hungry, or you look sad, or you look frightened. And the infant learns to identify the affect as an emotion. And that process of being able to think of it as an emotion helps us to regulate. When we stop and think about, what is it that I'm feeling right now? Oh, I'm anxious. Then it becomes more regulated. So most, like I said, mentalizing is automatic, it's implicit, it's something that we do unconsciously. In the therapy that we do, we're trying to find places where mentalizing breaks down, and where the mother goes offline, becomes dysregulated, and needs to engage in explicit mentalizing, which is deliberate, conscious, it's very hard work. These are just some examples of explicit mentalizing. Did he just look away because he's angry? Or is he preoccupied with something else? I wonder if you're feeling guilty because you know that I'm disappointed, and so on. Now, one of the key things in terms of understanding mentalizing and affect regulation is that as emotional arousal goes up, the capacity for mentalizing comes down. If you're seeing your child about to be in harm's way, you're not going to stand there and say, oh, I'm feeling scared. You're going to jump in and do something to protect your child because your arousal is up and you need to act. That's a really healthy response. The problem is many of the mothers we work with have their arousal heightened much of the time. And so their mentalizing is offline much of the time. It can just take like a conversation with a DCF worker, or an interaction with a drug counselor, or something that the child does that gets mentalizing offline. And so the first step in emotional regulation that you probably often teach people to do is something behavioral. Count to 10, leave the room, go take a bath, take a nap. Those are all effective to a certain extent, but they don't really help build our understanding of how we get to impasses in relationships with children or with other adults. And so what we're trying to do is help mothers to mentalize when they're emotionally aroused so they can stop and think about what is it that I'm experiencing, and how did I get here? And then we believe that the behaviors will follow from those kinds of insights. Now, some of you may be wondering, what's the difference between mentalizing and mindfulness? Well, mindfulness is really part of mentalizing. It's sort of the first step of stopping and saying, what is it that I'm feeling now? What is it that I'm experiencing? What's going through my mind? Then with mindfulness therapies, the process is really of letting go of those thoughts, just letting them pass. Mentalizing is more getting curious about them and wondering, how did I get to this point? What happened before that led me to feel this aggravated? What's driving my behavior right now? So it's really taking one step further to do kind of a functional analysis of how mental states work. And so one question you might have is, how does mentalizing develop? Well, Fonagy and his colleagues, Peter Fonagy, who's really the originator of this theory, hypothesizes that parents interact with children in ways that help them learn to mentalize. And that one of the things that they do is they reflect children's affect and emotion physically and verbally in ways that children learn, oh, that's about me, that's my emotion. And that the way that they do that is to not get dysregulated themselves, but to kind of mix their own reaction with a different kind of affect. We often do this when we're speaking in motherese. We say, our voice goes up and we say, oh, you look sad, you look sad right now. What's going on? And so it's an indication to the child, this is your emotion. I'm going to mirror that so that you can see your mind in my response to you. And then you're going to develop a sense of yourself over time. And so this is just an example of and an explanation of that process.
Luca is in the unsettled state, and Mum shows her concern with her facial expression. She wonders what is upsetting Luca and softly asks him if he's tired. Mum's face looks sad for a moment, mirroring the emotions she thinks Luca is feeling. Then she looks at him with a reassuring face to let him know that she will try to help him feel all right again. Facial expressions which show the baby that his feelings are understood help him to begin to understand his own feelings and develop his sense of self.
So the other question that you might have is, when does mentalizing develop? When do we become aware that we have mental states that are different than others and that change over time? And the best example of this comes from theory of mind research with the false belief test, where, and it comes around age 4 or 5, but it's actually developing as young as 2. Actually, I think in Mary's montage, she showed little infants responding to each other's emotions, and as toddlers. And so that capacity really starts developing very young, but it gradually becomes more complex and sophisticated, so that at around age 3 or 4, there's this experiment called the false belief test, where you bring in a box of crayons, or it looks like it's going to be a box of crayons, and you ask the child what's inside. What do you think is inside? And the child says, box of crayons. Open it up, it's got M&Ms. And then you ask the child, what did you think was inside? Well, before a child is mentalizing, they'll say, I thought M&Ms were inside. After the child is able to mentalize, they'll be able to recognize that they had a thought that was different before, and they'll be able to say, I thought there were crayons, but there are M&Ms. And then the researcher might ask, well, what does your mom think, who's out of the room? What do you think she'll think when she comes in, is in the box? And a child who has theory of mind will say, she'll think they're crayons. And a child who doesn't will say that they'll think they're M&Ms. So let's watch the before.
What's inside the box? Yeah, let's open the box and see what's inside the box. Can you help me open the box? Candy. What kind of candy? Right. That's right. No, it's just M&M's. Well, let's close the box for now. Later on, I'll let you have some M&M's. Okay, we're gonna close it up. We'll put everything inside. You gonna put that in the box? Okay, so what's really in the box, Matthew? Now, what's really in the box? Right. So there's really M&M's in the box. I'm gonna close it up. Now, before we open the box, what did you think was in the box? That's right. You know what? Your mommy is outside. She didn't see you open the box. Now, let's ask her to come in. Now, we'll ask her what's inside the box. Okay? When your mommy, who's not here right now, when mommy comes in the room and she looks at the box, what is she going to say is inside the box? Okay? Are you sure? Is she going to say M&M's? Will your mommy look at the box and say there's M&M's inside?
So he's quite sure. So here, watch this little girl.
No, Elizabeth. What do you think's inside this box? Have a look inside. Oh, well, let me have a go, shall I? You ready? So go. Go. What's in there? What's that?
Pencils.
Oh, right. Should we put them back in the box?
Yeah.
Should we put the lid on? Now, can you remember what's inside the box?
Pencils.
And what did you think was in the box?
Pencils.
Did you? Now, I'm going to show this box to Jay in a minute. What will Jay think is in the box?
Pencils.
So I did this with my nephew who has a 2-year-old niece. Or we did this with his niece. He really wanted, he got her informed consent. And then he asked, and then of course she didn't have theory of mind yet. And he was trying so hard to get her right. Don't worry, it'll come, This is that. So parental reflective functioning is really just the manifestation of the capacity to mentalize. It's how a parent makes sense of his or her child's behavior in terms of underlying states and emotions. We entered with a parent development interview that was developed by Ariana Slade. The PBI is coded on a -1 to 9 scale. A score of 5 is considered ordinary RF. It's really what we strive for in our interventions. Scores less than 3 indicate pre-mentalizing. And so here's an example of a pre and post PDI. The pre-treatment, this is the interview that we do with one of the mothers in our study before treatment where she scored a 2 and after treatment where she scored a 4. This is just to show you an example of the differences in reflective functioning pre and post.
Can you tell me about a recent time that Noah was emotionally upset?
I don't know. Well, he was sick all last week, so if he wasn't if we weren't cuddling in bed all the time, he was, when I had things to do, or I had to leave him with my mom for a little while, he was upset then, because I wasn't there.
And what was that like for you? It was emotionally upset?
It bothers me. It's hard. It's hard to leave him, especially to walk out the door when he's crying for me to stay. It's hard.
Yeah.
Very hard.
And what do you think it's like for him?
It's probably just as hard.
Yeah.
Can you tell me more about a recent time when Noah was emotionally upset? Yeah, on Sunday when he went to his dad's house, he was really upset. it's the same too when he comes to my house from his dad's, he gets upset. I don't think he really understands like separation. Well, I mean, he gets over it, but like the initial separating part, he has no trouble. Okay.
So you can see there that in the second question, she's able to think a little bit more about her child's mind. That he has difficulty with separation, that he gets over it. It's more of it, whereas in the beginning, she's just able to say he's upset, but she doesn't really have any model of his mind at all. And so this is actually, I know it's full of words, you don't need to read everything, but this is actually the model for our intervention. It's the research model. The intervention, because we can't provide, or we don't believe we can provide our intervention in isolation, because the mothers have so many different needs, both case management needs and also psychiatric needs, and they're in addiction treatment, we're bringing the program into the clinic. And so, and we're also providing our own case management for everybody who's in the research. And we also provide developmentally informed childcare for all of the children who are in the study, regardless of what condition they're in. And so what's unique is just the purple on the left. That's what's unique to the Mothering from the Inside Out intervention. And so I'm going to show you just briefly the components of the intervention, and then I'll be able to show you a bit of the research findings, including some new ones. So Mothering from the Inside Out, it's a 12-session supportive individual parenting therapy. We don't have a curriculum. It's more fostering a process rather than specifying a content. There's an emphasis on promoting the mother's capacity to mentalize, and to mentalize explicitly about her own mental states and also about her child's. And so the unique components of the intervention are the therapist takes a mentalizing stance, they mentalize for the mother, they help the mother mentalize for the child, and they also provide attachment-based parenting. Those are the unique components that I'm going to talk about. The mentalizing stance involves taking a not knowing stance, an inquisitive and curious stance. And so the therapist is the expert in the process, but not in terms of the content and not in terms of the information. It assumes that mental states can't be known for certain. So the mother can't ever be certain of what the child is feeling. The therapist can't ever be certain of what the mother's feeling. But it encourages the mother to make hypotheses and explore and to think about and to develop the mentalizing capacity, really to develop her own mind and her own model of her own mind and her child's mind. Simply asking questions about mental states helps to activate this process. And when the mother's mentalizing the mentalizing stance is lost, when the therapist starts explaining or interpreting or giving advice or suggesting behaviors, it actually takes the mother out of the offline in terms of mentalizing. So it's very important that the therapist is holding an inquisitive stance and allowing the mother to do the work. We start actually with mentalizing for the mother. It's an oxygen mask approach in that the mother first has, on the airplane when they tell you, first put the oxygen mask on yourself so you can breathe, then assist your child. Well, if the mother is dysregulated about something that's in her own mind, there's going to be no room in her mind for her child. And so we start with where the mother is. And we identify moments when mentalizing is lost. We explore mental states. We ask. So let's pause for a moment and talk about this argument that you had with your partner. What was going through your mind? And what was going through your mind before? Let's go back and see how you got there. Not so much in terms of behavior, but in terms of your thought process and your emotions. What were you thinking? And oftentimes, through identifying what she was thinking, what the fears were, what the anxieties were, what the anger was about, even though they're negative emotions, it helps her to make sense of how she got to this state. The therapist also lends their own mentalizing capacity to the mother. If she can't come up with an answer, the therapist might say, well, I was thinking that you might have been scared, but does that make sense to you? And so the therapist uses their own capacity, but it's always in a partnership or a collaboration to see if it makes sense to the mother. And the therapist also takes responsibility if they're wrong about something. Then, when the mother's regulated, there's a shift, and if the mother isn't keeping the child in mind, the therapist is. And so there's a shift to talking about the child as though the child has a mind. And so if it was, let's say it was a conflict about what the child was going to wear and getting out of the house and making it into the clinic on time, once the therapist has talked through and they've had a chance to mentalize the stress for the mother of that situation, then she can ask, and what do you think was going through Annie's mind? Why was she so insistent on picking her own clothes? And at this point, the therapist also brings in relevant developmental guidance about what a 2-year-old is thinking, or how a 2-year-old's sense of time, or the investment in the now and play behavior versus being able to think about the future and plan. And so, but the important thing is that the therapist is keeping the mother online in terms of being curious and interested in her child's mental states that are underlying the difficult behavior. Attachment-based parenting involves giving guidance about the child's cueing and miscueing, and also behavioral guidance for the mother about the child's emotional needs and the mother's role as a secure base and a safe haven. All of our therapists are actually trained in the circle of security, and we keep the circle of security poster handy so that they can talk about the children's attachment needs and behaviors on the circle. So now I'm going to talk about our randomized clinical trials. We have the control group and the out-of-control group. That's the treatment group. We've completed 2 randomized clinical trials. All these trials have taken place where we've been embedded in the outpatient substance abuse treatment clinic, where most of the mothers are in methadone maintenance. So we've completed 2 randomized trials, and we're now in a 3rd ongoing trial. So we've done 2 trials where we've done the therapy, and we've found, I'll be talking about the efficacy in a minute, but now we're 2/3 of the way through a trial where we're training addiction counselors to do the therapy. As you know, and it's been talked about all day, about how going from research and scaling up to the population level, there's often a drop, and in research there's often a drop in efficacy. And so now there's a new model for doing this research where the research is really held responsible for, the researcher is held responsible for sticking around, providing supervision across the whole trial, not just parachuting in, training, and leaving, but sticking around and learning how to train, and then seeing if the training is effective, and also doing, as Mary was talking about, adherence scales, looking to see is the therapist doing what they're supposed to be doing. We've also done a couple of pilot studies, one with mothers who are in treatment for mental health, where we trained mental health clinicians in New Haven, and another one in the Western Cape province of South Africa, where we train clinicians in tertiary or public hospitals who are working with highly stressed parents. But I won't be talking about those findings today. So just to give you an idea of our population, the primary drug of choice is heroin and prescription opioids. Many have a co-diagnosis of depression, anxiety, PTSD, or personality disorder. Most are child welfare involved, receiving public assistance, have limited or unstable families and social support, extensive trauma histories. A majority are Caucasian, and then a large minority are African American, and a smaller minority Hispanic. They all have to be enrolled in outpatient addiction treatment in order to receive services. Children in our first trial were between birth to 3. In the second trial and third trial, they're between 1 and 5. And so just to show you, the comparison intervention includes all the same wraparound services, but there are differences in the actual intervention. So in the comparison intervention called PE, or parent education, we've created a series of very readable, brief pamphlets about all the parenting topics that mothers have brought in over the years. And so it's individualized in that way. The mother chooses the pamphlet, but it focuses on parenting strategies, on self-care, and on interpersonal relationship strategies. That's what's different than MIO. And what's similar is it will provide developmental guidance, and both also involve building a therapeutic alliance. So we try to keep it similar in terms of the intensity and the generic aspects of it, but want to see if the mentalizing piece makes a difference. And so what we found, and these are the publications. Feel free, I'll give you my email address at the end. Happy to send you the publications. But since it's in writing, I'm not going into a lot of detail here. I just want to show you what I think are the most interesting findings. In terms of primary outcomes, in both trials, maternal reflective functioning was higher at the end of treatment for the MIO group than the PE group. We also found that we observed interactions, and I'll show you that data in a minute, mother-child interactions. We found that mothers' interactions were more sensitive, and there was better reciprocity. In the first, we used different assessments in the first and second trial, so I want to jump to the second trial. This is the design. We have 4 weeks of baseline assessments, and the assessments are used in terms of informing the therapist about the patient before they start the treatment. All the assessments are videotaped. We then have 12 sessions of the intervention, 4 weeks of post-assessment, and then 13 weeks of follow-up. This is the PEI scale that I talked about. And these are the findings from the second trial. And as Dan mentioned earlier, for a D code, we interpreted a D of greater than 0.2 to be a notable effect. And I'm sorry, this is a typo. So at post-treatment, there was a difference in terms of RF. And at follow-up, the difference actually became larger. That should be greater than 0.5. That's a typo. And then in terms of the child's interactions, we used Ruth Feldman's CIB coding method, where we show the child a series of novel toys that are likely to increase uncertainty. So we go to the local Natural History Museum and buy all these scary bugs and creatures and put them in the box. Because the idea is we want to see how much does the child use the mother as a secure base, and also how does the mother respond. And we also look at the dyad. So we use the CIB. It's coded on a scale of 1 to 5. And again, we looked at behavior at a 1-year follow-up. So it's pre, post, 3-month follow-up, and 1-year follow-up. And we found delayed effects in the interaction, but by the 3-month follow-up, the MIO mothers were showing great sensitivity, and that gap was increasing at the 1-year follow-up. And pretty much the same pattern for their dyadic reciprocity. Now, we also looked at child attachment at baseline and post. We didn't find group differences in attachment security at the end of treatment. So PE and MIO were similar. However, what we did find was that mothers who had more severe addictions, so if they started using drugs earlier, if they had family histories of addiction and mental illness, if they endorsed more symptoms of drug dependence, those mothers were likely to have children whose attachments became more secure. If they were in MIO, if they were in PE, that wasn't the case. So it seemed that MIO was particularly helpful for the children whose parents had the most severe addiction. I think it speaks to the question of matching for treatment and who is going to benefit the most from this treatment. We also found in the second trial that mothers who were in MIO were more likely to have fewer relapses. And so we think there might be a connection between improving the emotional regulation in the RF and reducing substance use. And then finally, we found support for what we proposed were the mechanisms of change in the intervention. So when the therapist made efforts, it could be that just the therapist being warm and present and having a strong alliance would lead to changes. So we actually used our measure, the adherence measure that Mary showed you, we used it to see if what the therapist was doing made a difference. And it was a rigorous comparison because we included the therapist's efforts to build alliance along with their efforts to mentalize, along with their efforts to work on behavior. So we measured all of those, and what we found was that the therapist's efforts to promote mentalizing did predict the mother's improvement in mentalizing. And then we looked at the mother's improvement in mentalizing, because along with her improvement in psychiatric symptoms, her improvement in substance use, because it could be that if you become less depressed and you stop using, your parenting's going to improve. But what we found was it was the mother's improvement in mentalizing that predicted her sensitivity with her child. And then finally, there's a big question in attachment research about what's the role of mentalizing and sensitivity in relation to attachment. And we found that the mother's mentalizing led to improvements in sensitivity, which in turn led to more secure attachment. So there's support for the treatment model. Now, another interesting finding that I want to point out is we looked at, how I said in the beginning, in the treatment, we focus on mentalizing for the self first, the oxygen mask, and then mentalizing for the child. Well, I was interested in what's the relationship between each of those and the mother's parenting. So in the first trial, I was able to develop two measures, to take the PDI and factor analyze it into two scales. One which is self-focused RF, so it's the mother's mentalizing about her strong emotions and their impact on the child. The other one is mentalizing for the child's strong emotions and their impact on the mother. Interestingly, what we found was it was the mother's ability to mentalize for herself that was related to her parenting. And so this may not be true at the population level, but with the mothers who we're working with, who are very high risk and tend to be very dysregulated, developing that capacity to think about their own emotions and regulate their own emotions is really important to their parenting. So I'm just going to end by telling you about the trial that we're currently doing. We're training 20 addiction counselors to deliver either PE or MIO. They're randomized to treatment. And the first question that we have, and I think this also built on Mary's work, is does the clinician's level of RF matter? So we think that it does, and there's very little research out there, very little, about clinician RF. But what I did find led me to think that the clinician's level of RF does matter. It needs to be higher than the patient. But the clinician also has to come down to the patient's level of RF. They can't be working at too high a level. This is just all common sense. And so we developed a measure of clinical reflective functioning that's parallel to the parent reflective functioning, where a score of 5 is ideal. Here are some of the clinicians who we've trained, and these are the findings from 15 of them. And so we did find that clinicians in the MIO training were able to increase their level of RF towards a 5, and that there was a significant difference between the two conditions at the end. So I'm going to wrap it up there now because I'm out of time, but stay tuned because we're just now starting to analyze our results. And actually, and I did just 3 days ago look at the data of clinicians' RF and the patient's RF and found that the clinician's level of RF at the end of their training was moderately correlated with the patient's level of RF at the end of their treatment.
Yep, we have time for questions.
Opportunity for questions again. Anyone have a question that they'd like to put up to? Oh, our traditional questioner up here. They're always good questions.
Hello again. I found that very interesting and I have a few questions.
Sure.
Was there ever a plateau necessary of women who are having addiction? Is there like a plateau?
Right.
Amount of years, things like that, I guess you said that it was higher risk or higher addiction numbers were seeing greater MIO results.
Yes.
What would you say in general, like what would it be, a teenager in high school experimenting with drugs or?
Well, on average, so most of the mothers in our study come they're there voluntarily because it's research. They're volunteering to participate. And the average age is like 30. So and oftentimes they're mothers who have lost custody of children previously, and they're coming in saying, I want to get it right this time. And so we haven't worked with teen moms. In fact, our eligibility criteria is 18 and older. We haven't found any differences in terms of age, in terms of history of substance use. The only caveat I would say is if a mother is actively using to the extent that, well, usually if a mother is actively using, she's going to withdraw from treatment for a while, and so she won't be in treatment. But that is something that you do need to pay attention to. She has to be at least getting stable enough in her recovery that she's going to benefit from the treatment.
And then one more. Have you done any work with incarcerated mothers?
We haven't done work in prisons, but we have, most of our mothers have histories of records, and some of our mothers have actually become incarcerated like during the follow-up period, and so we stay in touch and they come back when they're released. But I think that would be a really good population to work with, and I believe there's a researcher at Columbia, I'm forgetting her name, who has done work with mothers. Mary Byrne. Yeah.
Mary Byrne?
Yes, Mary Byrne. That's right.
Hi, also found this very interesting. Wanted to know, have you considered, because you talked about mostly opioid addiction, working with mothers that have addicted to other drugs and alcohol?
Yeah, so a small portion of mothers who come through our program, their primary drug of choice is alcohol or marijuana. And then there's a slightly larger percentage with cocaine. So we haven't restricted it, but it's just that the sample in the clinic who's getting treatment is primarily mothers who are either in methadone maintenance or buprenorphine. Yeah.
Other questions? Back to you. Oh, back up.
Oh, thanks, Dave. Another old question, perhaps. So we train our students, hopefully, and this is also true in the other professional schools, I think, in CBT. And so they would probably be most familiar with the language of CBT. Some of their clients, therefore, would also come to know some of the precepts of CBT. You did a nice job of explaining the difference between mindfulness and mentalizing.
Right.
Can you also give us just a brief description of how you communicate about the difference between teaching mentalizing and teaching CBT?
Yeah. So CBT, I think, is also involves a piece of mentalizing, which is thinking about different thoughts and emotions and testing them against reality. Here, we're more trying to help the mother develop or expand a model of her own mind. So to link the pathway of mental states that got her to this point. And the other, we're also not trying to get rid of the affect, we're trying to actually tolerate the affect. So not necessarily to think a way out of it, but to sort of be able to tolerate, experience it, and think about how it came about. Is that it?
Thank you.
No, it is back.
Okay. First of all, thank you.